Welcome back, VMR community, to a very special RLR edition with the one and only Yusuf. Actually, Yusuf, I don't know how to. I was going to say Dr. Saklawi, but how do you pronounce? Yeah,
Yeah,
really?
just like that.
Let's talk a little bit. First, I want you to just share with us what's behind you in that whiteboard. Teach us 2 minutes of what you've been thinking about.
Make a video about the metabolism of vitamin D. I'm just kidding. That was the teaching. That was the last teaching behind me.
I love it, man. The last person I knew with a whiteboard like that was Gurpreet Dhaliwal. So you are in good company. All
Yeah.
you got to do is lose your hair now, and you'll be one of the elites. Um,
Give me 2 years.
guys, who is scribing today?
I'm scribing.
Oh, wonderful. How are you, Valeria?
I'm good. Hi everyone. It's been a while since I last scribed, so but I'm really excited for the case.
Let me ask you, have you read all those books behind you, or is that more for like making the scene look very sophisticated?
I guess both. I do have like this challenge this year of reading one book each week, so I've been
Wow.
trying to find really good books to get me going and not, get on a reading slump. So I can proudly say that I have read most of them, if not
That's
all.
incredible. Congratulations to you. I'm trying to do one book a year. Going on to who's doing the teaching. Who's doing the teaching?
I'm doing TPs. Hi.
How are you, Lara?
Oh, I'm doing good. I'm finally done with all the exams from my med school.
Congratulations.
Yeah, so I'm finally a free person.
What are you going to do with your free time?
I'm gonna do nothing.
Now, my main question is who is co-discussing with Prof. Rez? He's been quite silent, maybe aspirating on an acai bowl right now. Or maybe he went to the bathroom. Who knows? I don't see him right here. But the co-discussant is Ravi, and he's going to tackle the first aliquot. Oh, there he is. Dude, open your mouth and say a few words.
Hello.
Well, we'll leave it at that. And then, Yusuf, when you're ready, share the first aliquot. Make it very tricky because you don't want this diagnostician mathematician to get it too quick for us.
He will. I think he might. So today the case is 7 aliquots. Not a lot of information per aliquot, so hopefully you'll be able to extract a lot of data from it. So whenever Vali, you're ready to share the screen, we can get started. And Vali, I did send you the case on WhatsApp if that helps you with describing as well. So this is the case of a 35-year-old male who was brought in for progressive somnolence. So on initial evaluation in the ED, he was very somnolent. He was minimally arousable. They got a VBG, which showed a pH of 7.04 and a PCO2 of 117. And he was placed on BiPAP. And that's the first aliquot.
Yeah, Yusuf, I just had I just had a soft-boiled egg, and what does that have to do anything with your first aliquot? I think this is a classic chicken and egg dilemma. Is the patient confused because they're hypercarbic, or is the patient hypercarbic because they are confused? And I think how we draw the arrows between altered mental status and hypercarbia is very, very important. And so. Gosh, sorry, there's a really loud noise outside. Hopefully it ends soon. But the arrows go both ways. Patients can get confused for reason X, and they stop breathing as well, and they start become hypercarbic, and the other way around. So, what can you use to help you try to make progress? Of course, there are many other things, but since we're gonna we have little data to work with, I think you can analyze and get more juice out of this VBG than just hypercarbia. Based on the degree of hypercarbia and the degree of acidosis, you can crunch the numbers, but I won't, to try to figure out, is it acute or acute on chronic or chronic? And here I will tell you the numbers will probably crunch out that this is acute. Why? Based on how low the pH and how high the PCO2 is. So then you can ask yourself, okay, what's more common? acute brain disease resulting in hypercarbia, or patient with acute lung disease causing hypercarbia, causing confusion. It's much, much, much more common for a patient to have chronic lung disease than get acutely confused than it is for somebody. I'm sorry, I said that wrong. It's much more common for lung disease causing hypercarbia, causing confusion, to have some chronicity to it. In stark contrast, patients with brain disease, especially if it's acute and devastating, can become hypercarbic very, very quickly. And so I think I would really worry that this VBG demonstrates pure acuity, and pure acuity implies that the lungs are probably healthy, which has me worried that the bicarb may be a bystander to an otherwise serious intracranial process. I would have made that assumption anyway, because I know that the hypercarbia is something we need to treat, and we're going to be treating that no matter what. And so it would be premature to just say, okay, I'm going to treat it and focus on that as the only culprit. So acuity implies that there's probably something going on in the brain, and that the hypercarbia is a consequence of that rather than a cause. In reality, most of these instances it's neither a consequence nor a cause. It's in the middle, it's a contributor. And the patient has something else going on, and the hypercarbia is definitely not making it better. So let's get this patient breathing and try to get the PCO2 down and see what we're left with. I wouldn't be surprised if we learn that there is something else going on in addition to hypoventilation. Any thoughts on that, Prof. Rez?
That was beautiful. Zero to add.
Awesome. So let me give you some more information. So he works at a supermarket as a manager, has 3 kids, doesn't smoke or drink, only takes some inhalers at home. So he was previously hospitalized at a neighboring hospital. And from your review of the previous hospitalization, he has a history of heart failure with a mildly reduced EF. So his EF was 45 to 50%. And they had noted severe RV dysfunction at that time as well, in addition to the mildly reduced EF. They called a chronic hypoxic respiratory failure, NOS, like without like specific etiology. He's on 4 liters nasal cannula, and he was placed on nocturnal BiPAP since that admission as well. So these were like his previous comorbidities. In terms of what brought him here today, so per the family, he has like 2 weeks of progressive dyspnea, cough, had a few episodes of nausea, vomiting, and this was like on the subjective. And before coming to us on medicine, they did get a CTPE, and it did show bilateral subsegmental PEs, large pleural effusions, and severe right heart enlargement. And I'm gonna pause there for you all to comment on the background and the findings that we just found.
I am really loving this case, Yusuf, and I'm loving it because the case I plan to present to Rabih is between 2 cases. One is Name That Bug. Rabih, it's going to be a new format for RLR, but the other is exactly this, and I love it so much because cardiovascular pathophysiology is so logical, and once you understand each of the chambers and their role, the rest of it becomes quite simple. And here, I'm very curious to this patient's weight, to be honest, because we do know that the patient is on nocturnal oxygen, and the primary reason that someone might need BiPAP or oxygen at night is an elderly smoker COPD, but in middle-aged folks without COPD, obesity. So I'm very curious to know if this guy is overweight and does he have obesity hypoventilation syndrome. Now, something that really grabbed my attention is when we looked at the echo, Yusuf told us that this patient's EF is just mildly reduced. I believe it was 45%. Thank you. Shout out to the scribe. And so then you have to ask the question, this severe RV dysfunction, is it expected in the context of mildly reduced EF? No, absolutely not. So many patients have heart failure. And when we say heart failure, really what we mean for most comers is LV dysfunction, leading to improper oxygenation and perfusion of tissues. But most patients with left-sided heart failure do not have severe RV dysfunction. So already there's a mismatch there. So now my mind is saying maybe the LV stuff is a distractor, is a red herring. And really the focus should be the RV, the right ventricle. There's a very important teaching point that we have to make here is that heart failure is ultimately a clinical diagnosis. Even if someone has an EF, you could say the EF is mildly reduced, but you can't say they have heart failure unless they fit the clinical syndrome. They have to fit the clinical syndrome. So now I'm like, okay, why does the RV get dysfunction? This is where I think the pathophysiology of the cardiovascular system is beautiful. You just have to know that you really have 4 chambers, like 2 sides. The goal of the right system is to take deoxygenated blood, pump it to the lungs, oxygenate it, where it comes to the left side, and the left side distributes it everywhere. So then the question becomes, is the lesion upstream of the RV? You can start with the left ventricle and move your way back. I don't think it's the left ventricle, to be honest. I mean, there's some dysfunction there, but it's way too mild to cause this degree of RV failure. Then you go to the pulmonary vessels and you ask the question, well, is this pulmonary hypertension leading to RV failure? This is where I think a CT scan would be really helpful. And then further scrutinizing the echo on the amount of tricuspid regurgitation. Or is the issue at the RV itself? The RV, whether it's the valve, the myocardium, etc. So I am really curious to know what is causing this RV to fail. I'm going to look at a cross-sectional imaging to look at the pulmonary vessels. I think right heart cath, where you evaluate the pressures in each chamber, can be very helpful. And even stuff like a cardiac MRI to just see what is the function of this RV. So what this background information does for me, Yusuf, it tells me that this patient is really vulnerable from that severe RV dysfunction. And something like a pneumonia, which sounds like this patient has, or a viral URI or viral respiratory process, can tip them over to the point where they just can't compensate. You know, if someone is so vulnerable, it doesn't take much to tip them over. So yeah, I mean, I'll pass the mic to Robbie to layer upon that. But for me right now, this is a vulnerable patient, probably got sick, probably got pushed over their tipping point. But I think the money is, why is this RV failing? And I don't think it's the left heart. I think it's either what's happening in the pulmonary stuff or the RV itself. But we have an armamentarium of diagnostic tests that can help clarify where the disease is. Dr. Jeha, anything to add?
Not a Prof. No, I'm so intrigued by this. I think we're going to study, as you did so well, the RV failure that the patient has. We have to also study the inflammatory features of the last 2 weeks. And in parallel, try to merge the hypercarbia. And all those things are in 3 separate buckets for me. I think the inflammation, the hypercarbia, and the likely pulmonary hypertension the patient has. And so I think the question in my mind is, what happened to how did the analysis of the first aliquot change with this new information? And I think when you have the patient having been prescribed oxygen, using inhalers, you do have to reassess your calculus and come to the likely conclusion that the patient does in fact have respiratory compromise that's driving the hypercarbia. And so I wouldn't be surprised if we examine this patient, come to the conclusion that they have obesity hypoventilation syndrome, and the clues will be, of course, the BMI, but also the bicarb. I can't really excited to see those things. Because all of a sudden, I think Prof. his chief concern becomes not really our chief concern. And it becomes very plausible that the reason he's showing up as confused and hypercarbic is not because that's the driver of a disease process, but that's actually the manifestation of his vulnerability. It's no different than somebody with CKD getting bacteremia and showing up as AKI on CKD. The AKI on CKD is just a consequence of something else. And so somebody who has obesity hypoventilation syndrome showing up as somnolent is just that, is progressive respiratory failure. The question is why. So I'm really curious to figure out if we really have three problems, hypercarbia, inflammation, and pulmonary hypertension, or if we really have two. And I think the BMI, as you alluded to, and the bicarb will help us make a lot of progress. Very,
Yeah.
very.
And I wanted to ask, does anything in the what would satisfy you to explain a respiratory failure? Because you see like the previous history is like, oh, they were just discharged on oxygen. Do any of these diagnoses like satisfy you? Like, oh, maybe if it was vascular disease or if it was heart failure, or what would be enough to satisfy you to be like, okay, maybe they do need oxygen at home?
Oh, I mean, Yusuf, that's a really good question. And by the way, not to be a politician here, we didn't comment on the pleural effusion, but the pleural effusion affects the diaphragm's ability to contract, which will affect your ability to ventilate properly. So that's yet another vulnerability. So that I think when Robbie said inflammation, it was something I neglected to say, is the PEs and the effusion. As far as like what would prompt me, why do we even give oxygen therapy? Well, the reason we give oxygen therapy to folks who are hypoxemic with exertion or when they sleep is because unlike other pulmonary other vessels where the arterial system dilates when it's not having enough oxygen to increase perfusion, the lungs do the exact opposite. So all these poor patients with like obesity hypoventilation syndrome, COPD, if they become hypoxemic, it causes worsening vasoconstriction within the pulmonary vessels, and that would lead to worsening pulmonary hypertension, and that would lead to worsening RV function. So just like that patient with aortic regurg where you want to afterload reduce, the patient with RV dysfunction, the last thing you want is to add an additional insult, which would be pulmonary hypertension. So what I would say to the audience is that at the end of the day, like when you're giving someone oxygen, it's primarily for the objective finding of hypoxemia, and long-standing hypoxemia, one of the greatest sequela is pulmonary hypertension, the one that we most fear.
Awesome. Excited to give you the next aliquot of information because it's everything that Prof. Rez asked for. So the patient actually was initially diuresed and developed hypotension, admitted to the cardiovascular ICU. He was started on dobutamine and diuretics. They repeated the echo. The repeat echo also showed mild reduced EF, severe right heart disease, severe pulmonary hypertension on echo. So they went for a right heart cath. So I'm going to give you the information, which I sent to you, Vale, as well. So the RA pressure was elevated at 19. The PA pressure was 49. And the wedge was 25. And the PVR was also elevated at 10.45. And I'm going to put that information in the chat. These findings, actually, I'm not going to explain the findings. I'm going to leave that to you. And then underwent cardiac MRI as well. And the cardiac MRI, the findings were severely dilated right-sided chambers, and then the possible infiltrative disease of the myocardium, but not like definitive. They left it like vague. And that's the third aliquot.
Oh, very, very intriguing. Yusuf, can I just clarify? Is the plan to talk about the somnolence? Do we know? I mean, he's in the MRI machine, so presumably either he's intubated or he woke up. Is that data coming later, or should we?
Yeah, because right now he's in the ICU, so he will come to my service next aliquot.
Okay, sounds good. Yeah, I think that it goes to show you how hard it is to solve this problem without being able to exonerate or to assess the likely working hypothesis that he has obesity hypoventilation. And that's really making it hard for me to analyze the whole picture. But if we focus on just the cardiovascular status, I think that when you're invoking somebody having cardiovascular disease and getting hypotensive with diuresis, that's an interesting space to reflect on. And, of course, you would question the association between hypotension and diuresis, but I think that it is true that you might not have diuresed somebody enough, and that they are essentially heading towards cardiogenic shock. And so that's probably the most common circumstance where patients with heart failure who get diuresed worsen, is that they have really, really severe disease and diuresis alone is not sufficient, and they need inotropy, which you gave them. The other possibility, of course, is that they don't have heart failure and there's something else going on. So to summarize, either it's really bad heart failure or they don't have heart failure. And the final category I think is the most interesting one, which is they have a very specific kind of heart failure, which is what's called preload dependent heart failure. And there the idea is that the reason they have elevated filling pressures is not because of progressive ventricular dilation, but rather because they have a focal obstruction somewhere. And if you think about somebody, for example, who has severe tricuspid stenosis, their JVP and their right atrial pressure will be through the roof because of the stenosis. But what will the RV be? The RV will be completely the opposite of that. It'll be empty. And so those patients have elevated filling pressures and they have JVD distension, IVC distension, lower extremity edema. And they definitely need to be diuresed, otherwise they'll have orthopnea, all those things. But the threshold to tip them over is very, very low. Why? Because they need some level of hypervolemia to be able to bypass the tight tricuspid valve and get some blood into the ventricle. And so those are called preload dependent patients. And any patient with any form of obstruction anywhere is preload dependent. And so if you didn't know that this patient had concern for pulmonary hypertension, you might use the fact that he got hypotensive with diuresis as a clue that he has some kind of obstructive physiology. And I think the question now is with the data is, where is that obstruction? And I'll pass the mic to Prof. Rez to do the hard thing, which is to analyze the Cath data and the MRI.
To be honest, Robbie, you made analysis of the Cath data easy based on all the teaching you've done in the past. I don't want to say easy because also it's interesting you said how the brain works, right? Like if I don't think about something for 6 months, even if I spent hours studying it, it's going to be hard for me to recollect it easily. So I'm going to do my best here, but I'm definitely going to rely on Robbie. And maybe Robbie, while I'm going through this, you can identify one schema from Evernote or something that really highlights what I'm doing, or what you think I should be doing, because you're going to have to guess. But okay, so in that first aliquot, Robbie was like, I'm most concerned for pulmonary hypertension because and that's probably the most common cause of RV dysfunction without LV dysfunction, right? Because like, how hard would it be just to affect the RV through another disease entity without touching the LV? So this is a beautiful case because we don't really have a terminal diagnosis yet. We have a proximal diagnosis. And at this point, like, my complete focus is pulmonary hypertension causing RV dysfunction, but I just temper that slightly because of the PE, the effusions, and the cardiac MRI showing the possibility of infiltration. And if you ask, how does the cardiac MRI do that? Well, they give the patient gadolinium and they see if there's any kind of enhancement. If there's enhancement, just like when we give gadolinium and MRI of the brain and the spine for all you neuro nerds, if there's an inflammatory process that breaks the blood-brain barrier, you get enhancement. And it's a similar process here. If there's an inflammatory infiltrative process, there's enhancement. But even if there's ischemic disease, there's enhancement. But it follows the natural flow of the coronary vessels, unlike infiltrative disease, which is random and scattered. It does not respect the territory of the coronary arteries. So here we know for sure the patient has pulmonary hypertension. But you might say, wait a minute, Rez, is this all due to the left side of the heart? I didn't need this Cath to say, no, it's not. Like, just the history alone and the degree of RV dysfunction that's out of proportion to the left side, which is the most common cause of pulmonary hypertension, it was enough to say we're going beyond the left heart. And what these numbers do is they confirm, one, you have pulmonary hypertension, because look at the mean pulmonary arterial pressure. You definitely have elevated left-sided pressures, because look at the pulmonary capillary wedge pressure. But you can actually calculate the transpulmonary gradient or look at the PVR to say, hey, does the left side explain everything that's happening in the right side, in the pulmonary vessels? And the answer is it doesn't. that really high PVR is telling you that you're having also non-left-sided pulmonary hypertension, specifically pulmonary arterial hypertension. And now the question becomes, what are the diseases that cause that? And we all, I mean, if you're just joining us, there's an awesome like mirror image 1, 2, 3, 4, 5 for the causes of pulmonary hypertension. I'm not going to actually teach about that, but I'm sure someone can, refer a link or an image online or something like that. But yeah, Yusuf, I think I'm going to look at this guy's history. I'm not going to blame the left side of the heart. Group 3 is the lung, and we don't really have a history of lung disease. And he might have some obesity, hypoventilation, but it just, again, that pulmonary vascular resistance is pointing me towards that specifically not the broad term pulmonary hypertension, but the specific term pulmonary arterial hypertension. And so now the question becomes, what can cause that? Well, I would love to pass the mic to Robbie to maybe share his schema and like, one, if he agrees with my localization exercise, and then two, like what would be the next steps?
Prof. Raz, 100% completely agree with you. I think I'll just get some juice out of the number that Yusuf shared at the end, which is the RA to pulmonary capillary wedge pressure ratio. So if you just take an example of pure primary pulmonary hypertension, in that instance, the RA pressure is going to be much, much, much higher than the pulmonary capillary wedge pressure. Okay, and in the scenario that is exactly the opposite in a patient who has left-sided heart failure, who has not yet developed severe pulmonary hypertension as a result of that left-sided heart failure, their pulmonary capillary wedge pressure is going to be very high and their RA pressure is going to be underwhelming. So the relative elevation of the right atrial pressure to the pulmonary capillary wedge pressure gives you a sense of how much more to lean towards pulmonary hypertension that is precapillary versus how much more to lean towards postcapillary. So in a pure precapillary disease, the ratio is very, very high. In a pure postcapillary disease, the ratio is very low. And the cutoff to start to lean one way or the other is 0.8, meaning that if you're above 0.8 or above 0.1, you're much more likely to be pre. And if your ratio is high, if your ratio is high, you're likely to be pre. If your ratio is low, you're likely to be post. It's a very simple, elegant way of capturing what Prof. Rez just said, and I think this number is in the intermediate zone. And so, what do you do with it? I think you realize that it's confusing. And so, here's what I'm doing, Prof. Rez. I thought Evernote was for your eyes only, but today we'll be generous. So the truth is, I think this is where we are. Both the LV and RV are down. The LV is down, pulmonary capillary wedge pressure is high, it's not normal. And the RV is down because, as you said, there's a disproportionate amount of pulmonary hypertension. So what's happening? And you told us the most common cause, Prof. Rez, is the LV causing RV disease. You already told us that. But I think people underemphasize that RV disease can also cause LV disease. And long-standing pulmonary hypertension. So Mengyu in an academy session taught me this concept. And she had a patient who had long-standing primary pulmonary hypertension, proven, who subsequently, because of the compression of the RV on the LV, compression on the coronary arteries, all sorts of really interesting mechanisms, long-standing RV disease can result in LV disease. Of course, it's also possible that a patient has synchronous disease in both ventricles at the same time, rapid onset myocarditis as an example. So the truth is, we have a rough sense of what the patient's time course is based on the history that this has been long-standing. He's evaded diagnoses. Nobody's been able to figure out what's going on. He's been put on oxygen. So I think that it's unlikely that we're dealing in the leftmost category. And so the question is, which category do we invest in? Do we invest that the LV caused the RV, or do we invest that the RV caused the LV? And I think, Prof. Rez, I'm really curious what your take is, because the base rate would say, stop talking, Ravi, this is LV disease causing RV disease. But here's two reasons why the base rate doesn't apply necessarily here. One, this person is very, very young. These diseases are not diseases of young people. LV failure in a young person is not common. And two, look at that MRI. The amount of right-sided dysfunction this person has is remarkable. So I think what would happen in real life is what probably happened to him in his prior admissions is most people assumed that he has LV disease causing RV disease, I would guess, because that's so common. But I think that's an assumption fraught with error because of how bad his RV disease is, and the fact that he's a diagnostic mystery. So I think we should be open to the possibility of the unusual here, that he has had long-standing precapillary pulmonary hypertension that has resulted in left-sided disease, camouflaging the true origins of where his problem lies. So the pleural effusions right greater than left, and maybe that he now has LV disease from long-standing RV disease. And so, Prof. Rez, I'm really fixated on trying to figure out why he has primary pulmonary hypertension. But let me stop there, and because I think that's a tricky thing to try to get out of my head. So I'm curious what holes there are, or what other things you want to add.
If I can just say one quick thing, Yusuf, I've never heard of that RA to PCWP ratio, but it's so helpful the way you explained it. And I think pulmonary hypertension is so confusing because of the terminology we use. But I just want everyone to picture this. Any artery becomes an arterial, becomes a capillary, becomes a venule, becomes a vein. We all agree. And the pulmonary artery is no different. The artery, the arterial, the capillary, the venule, the vein, which ultimately dumps into that left atrium. So when pulmonologists, or when Rabih uses that word, precapillary pulmonary hypertension, what is before the capillary? It's arterial. So it's really important to understand that pulmonary arterial hypertension is a specific subset of pulmonary hypertension. But if you understand that anatomy, then all of a sudden you learn about pulmonary venous occlusive disease, maybe something you didn't think about. So localizing exactly where is the lesion is critical. And big shout out to how like right-sided failure leads to left-sided. And I'm right there with you, Rabih. I think that this is pulmonary arterial hypertension. And I'm very curious to see what ensues or follows.
Yes. Sorry to give you the Cath numbers before the physical exam, but here comes the physical exam. Patient gets diuresed and gets transferred to my service. And on vitals, they're basically within normal limits, and his BMI is 17, which Prof. Rez asked for. On exam, he is very skinny, cachectic. On lung exam, it was like within normal limits. He did have like a loud P2, no edema on exam. The interesting thing was actually the neuro exam. He had proximal upper extremity weakness and the deltoids and the triceps, also in lower extremity weakness. He had weakness with dorsiflexion, and actually was not able to like walk a heel walk or on the toe. And then he had like diminished reflexes throughout. And then on the diaphragmatic movement, we did not note any abnormalities. And I'm just gonna pause there for comment, and then I'll give you more information in the next adequate.
You know, Rabih, I would love for you to just tackle the neuro stuff. And I'll just make a very quick comment because this case is so juicy in that, this, I think further strengthens the hypothesis you're not dealing with the common cause of pulmonary hypertension. And those common causes, probably the two most common causes, one, left-sided failure, which we've already established through the Cath results, that this can't be purely left-sided failure, and there is pre-capillary pulmonary hypertension. But the second most common etiology is lung disease. And that lung disease often is in the context of a longtime smoker or someone who's overweight. So groups 2 and 3 of pulmonary hypertension, the most common causes, all of a sudden are eliminated. And I think for me, Rabih, just the weight alone and the age, even without the Cath numbers, would have me chasing the more exotic and less common causes of pulmonary hypertension, specifically Group 1 and Group 5. Group 4 is the clots leading to pulmonary hypertension. These subsegmental clots, I doubt, are the cause. The pleural, there's way more going on to say that this is just chronic thromboembolic disease. And just recognize each of these can be additional insults. We're saying, is it this or that? No, it's probably everything. But what is contributing the most? I think this really verifies our gut assumption that it's Group 1.
Yeah, I couldn't agree more with you, Prof. Rez. I think that, my main reflection, honestly, is in modern medicine, analyzes data on a screen so far away from the patient. And for me, nothing beats actually going to the person you're trying to help and looking at them instead of your screen, which is ironic as I look at a screen talking about this patient. I recognize the irony of that. But Prof. Rez, he just came alive in my mind, and I think that this is not base rate. And I think we're seeing a young man who has a BMI of 17 who has profound neurological weakness, reinforcing the original concept of the hypercarbia here. The hypercarbia here is neurologic in origin. And why that may be the case is, I think, very interesting. But I think if we analyze the neuroexam and stay broad and link things together later, I think the neuroexam is quite interesting because he has proximal predominant weakness, which reflexively suggests myopathy. However, his weakness is in a distal pattern in the lower extremities, and he's hyporeflexive. So I think the localization is tricky here. And I think if I'm trying to be brief about it, it's the hyporeflexia suggests a peripheral nervous system localization from the get-go. And the question is, where along the nerve axis, from the nerve root to the plexus to the nerve to the neuromuscular junction and the muscle, there are features here of muscular disease, proximal predominance. There are features here of nerve disease, hyporeflexia. And whenever there are those two things together, I think you should be open to the possibility the patient has neuromuscular junction disease. I can't think of any that immediately match everything that's going on, but I'm open to all those possibilities because there are nerve diseases like ALS that can have proximal predominance. There are also muscle diseases, especially some hereditary ones that can have distal predominance. So I think the localization is broad here, and I think the value of EMG and a CPK can help move the case a lot further. So for the sake of time, I'll just leave it at that and see. By the way, I'll be back in 10 seconds. There's somebody at my door, but I can hear it all the way there.
All right, so let me give you some more information. And Reza, let me know if you want me to give an next 2 aliquot instead of 1. So in the next aliquot, we get some labs. So the creatinine is within normal limits. The serum bicarb is more than 45. So it's more than like the upper limit of normal in our lab. He does have anemia. His hemoglobin is 11.5 and MCV is 95. TSH was within normal limits this admission, and AM cortisol was within normal limits. PTH was just like mildly elevated. We got an ABG, like this is at this point, like after ICU, this is on the floor, and the ABG is 7.24, and the serum CO2 is 138. The CPK was within normal limits. And I was gonna pause here, but if you want, I can also just give you the next adequate information as well.
Yusuf, I follow
let me
you,
just give
man.
you the
Sure.
Yeah, I'll give you the next quote. So the SPEP and a UPEP are within normal limits. He got an acetylcholine receptor antibody that was normal. And then, like Rabih wanted, we got an EMG. And the EMG shows a myopathic process in a humeroperineal distribution with no membrane instability.
Haha, it's my turn to go first. Oh wait, no, it isn't. It's actually Robbie's turn.
It's you, man. I talked so much about the neuroexam. Go for it.
Okay. I was saying because I was going to give you the myopathic process in the humeroperineal distribution. But Yusuf, just to clarify, was that pH 7.24 or 7.04?
7.24.
24. Yeah, that honestly confuses me a bit because if we look at that first VBG, and honestly, for the purposes of acidosis and PCO2, like pH and PCO2, VBG is as fine as the ABG. And yeah, you can make some corrections, but it just is confusing that the PCO2 is going up, but the pH is also going up. And we looked at the bicarb, and you would expect the bicarb to be as high as it possibly can be. And actually, the body doesn't really go higher than 45. Like that's the kidney's maxed out right now. And the bicarb is primarily compensatory in mechanism. And it shows you that there is chronicity to the retention of CO2 because it takes days for the bicarb to go up. And these values, I know it was in the ICU, but Yeah, it's a bit surprising because the patient's on BiPAPs. I don't really know how to reconcile that. Like, unless he got amps of bicarb or the value is wrong. But yeah, I guess I'm just recognizing that like there's a mismatch in my mind. I would love to hear from you, Yusuf or Robbie, if you guys can clarify like what can cause the pH to go up with the PCO2, which is the opposite of what I would expect. But yeah, that's all I actually had to say, Robbie. I don't know if you can help me understand that part, or if you have any other thoughts before jumping to the more difficult part.
Oh, I'm intrigued. I'm so, the bicarb is super, super high. I wonder if the diuretic induced metabolic alkalosis helps balance the pH, but I think also the pH accuracy on the VBG versus the ABG also oscillates. But I'm giving you an explanation with as hand wavy as a seizure rather than with with any precision, Prof. Red. Did you want me to tackle the muscle stuff, or did you want to take it on?
No, the muscle stuff is all yours. Please keep going along that train.
Yeah, I think Prof. Rez, I'm intrigued. I think the muscle hypothesis, the big lesson we learned, Prof. Rez, is how you can have muscle disease without a high CPK. And I wish we had time to dwell on that, but that's not shocking. Surprising, but not shocking. And I think the EMG is very, very reliable to tell us that this is a muscle based disease process. I hypothesis that you might be more inclined to make because it's much more common to have a muscle disease overlap with cardiac disease than a nerve disease overlap with a cardiac disease. And so I think now you're saying, oh, wow, okay, I have the skeletal muscle involved, and I likely have the myocardial muscle involved. And I think, honestly, that's a little bit at odds with the hypothesis that this is all pulmonary hypertension. I say that because if you're following the hypothesis that a patient has a pan-muscular disease, skeletal and cardiac, the disease should localize in the cardiac muscles, not the vessel causing precapillary pulmonary hypertension. And so you might sit there and say, wait, hold on, how do I know this patient has pulmonary hypertension? Well, one reason we were so struck by it is because of the extensive chamber enlargement that the patient had. But now that you have another hypothesis, you might say, wait, is the chamber enlargement as a result of an intrinsic disease in the muscle rather than as a sequelae of pressure overload? And that might that hypothesis might better fit with the fact that on cardiac MRI, we see that there is enhancement in the septum and that's extending into the wall of the RV. Because typically, if you just have chamber enlargement or changes from pulmonary hypertension, the chambers are bland and not hectic and inflammatory. And so I think the hypothesis that this patient has an undiagnosed syndrome affecting cardiac and skeletal muscle is really, really gaining momentum. And I think this is at this point, you would probably really lean on your neurology colleagues because I think your neurology colleagues are probably much more savvy at understanding these syndromes than your cardiology colleagues. I only know of one or two of them, and the main one that I know about is myotonic muscular dystrophy, in large part because I actually just took care of a patient 2 or 3 months ago who had myotonic muscular dystrophy and learned that cardiac involvement is deadly in those patients. But yeah, I'll just leave it at that, Prof. Rez. I think that the case is really coalescing to have us worry about a hereditary muscular disease that is affecting both cardiac and skeletal muscle. And I think the way we would make progress is to bring in experts who know more about these diseases. Yeah. Well, what thoughts do you have?
I think that sort of like just highlights how beautiful clinical reasoning can be. Like, it's not your job to know all the inherited myopathies, but being able to actually frame it as such, like really in my mind, and I'm sure the audience mind, really clarifies what is the heart of the issue. And it's not the PEs, it's not the pleural effusion, but it seems to be some kind of storage disease that's occurring in the muscle. So I just love the way that you framed it all. And I do want to make a very important teaching point, because if you were a betting person with hyporeflexia that's more subacute to chronic, you would put the problem at the nerve, not the junction or the muscle. So how is it that this patient has hyporeflexia? Is it because Yusuf doesn't know how to do reflexes? No, never, never. You can never question Yusuf's team, the best team that for this patient to be admitted to. It's because look how cachectic the person is. They have no muscle to actually contract during the reflex. So at extremes, and be very careful when someone's this cachectic. Don't discard inflammatory myopathies. They may not have any CK to release. We had a case of actually really advanced paraneoplastic dermatomyositis at Hopkins, Robbie. The CK was normal, but the patient was, it was years, it was undiagnosed, and there was just no CK to go up. So I think those two things, I think it's a very important thing where you can have absent reflexes if you don't have enough muscle. You can have absent CK if you don't have enough muscle. So we have to take that with some caution there.
Awesome. And the next aliquot will reveal the diagnosis. Is that okay? Sounds good. And Robbie, I was wondering if you could make me a co-host so I can share screen. Okay, yeah. This is the schema I made alongside Jeffrey last week. Is that in general when you're yeah, Robbie style. So when you're worried about like myopathy in general, you want to start to look for extramuscular features to see if this is like a systemic disorder. So you might want to look for example, a glomerulonephritis. You're like, oh, could this be lupus? You want to look for rash or dermatomyositis, ILD, because these all could be clues as to a systemic disorder. Vasculitis can be very sneaky. Like you might think it's muscle predominant, but a lot of times it will end up on biopsy. You might look for clues on exams. In our patients, we didn't see any rashes, no arthritis. We didn't see any glomerulonephritis. And then for endocrine causes, we had sent like thyroid, parathyroid, adrenal, and pituitary. Those were all normal. And then in terms of infiltrative, like amyloid, sarcoid malignancies, they usually have a fingerprint somewhere else. Like this patient has been scanned from head to toe. Usually you will find it somewhere. And then if you jump to the muscle predominant phase level, which is at the bottom, which is you get to chronic, the CK levels are very variable, like you all said. Like it could be normal, could be elevated, so it's not a relevant diagnostic value. Well, then after you get there, you're in that space of like pure myopathy. How do you organize your thinking? Well, here actually there's like many ways to think about it, and many people have done it in the past. One way you could do it is like by age, is like which myopathies present in adulthood versus in childhood. So that narrows it one way. Another way you can do it is you can do proximal and which one involves distal predominance as well. Because if this patient was, for example, was 55, you would say, okay, this is classic inclusion body myositis. So this case, we have a myopathy that presents in adulthood and has distal effect. And then if you want to use a third scope, you can look up which myopathies involve the heart. Because then you're like, oh, could there be a myopathy that involves all three? And I don't keep those to memory. I know I have a paper that I always reference. I keep it in my notes, but I know that, okay, there are different patterns that I can look up. So in this case, we did consult the expert and they went through this thought process. We sent a autoantibody panel, a myositis panel, which was negative. Ended up consenting the patient for a gene panel for myopathies, and the gene for Nemeline myopathy came back positive, which is a myopathy that is actually, my teaching points on it is that there are two types of Nemeline myopathy. There is sporadic late onset Nemeline myopathy, which is people develop in their 50s and they just develop it. But there's a genetic form as well, which is inherited. And it causes both chronic respiratory failure and cardiomyopathy, and causes distal involvement as well. This patient was actually connected to pulmonology. The BiPAP teaching was done at home and is actually doing well. We did go back in the history and talk to the patient, and there are like some clues from childhood as to like, oh, I did have like a little bit of weakness keeping my head up, but it was not preventing the person from working. So it's not like you imagine somebody who has like this profound myopathy, you imagine them as like debilitated. No, this patient goes to work all their life, has kids, etc. And this was like the pattern of disease. So that's the case.
It's unreal. It's such a, well, I mean, I think that the case itself is so fascinating. The way you chose to tell that story, I think gets so much more juice out of it than we would otherwise would, including analysis of respiratory acidosis. What's the chicken? What's the egg? Where's the pulmonary hypertension? Is it pulmonary hypertension? LV, RV? neuromuscular localization, the lack of reassurance for the CPK, and then the schema at the end is just cherry on the top. This was really, really, really fascinating. Yeah, Prof. Rez, what are your takeaways? What are
Well,
your
I have a couple. One is like Yusuf, if everybody looks at his the infographic he created, I bet you that took him more than 20 hours, like 20 solid hours. And I don't know how your handwriting is so neat using the stylus. Like,
No, that's typed for sure.
oh, that's whiteboard?
Yeah. I typed
What?
it on a computer, and I chose a font that mimics like a handwriting that's close enough.
Damn, I was like, that's unbelievable. So maybe it took 19 hours. But one question I had, I thought it was just expertly presented, and I just loved your framework, and I'm gonna copy that for sure going forward. So this, I guess the patient didn't have pulmonary arterial hypertension. Can you tell us where we were flawed in our thinking about that?
So the patient definitely had pulmonary hypertension. The question is like, to what extent of what are the causes of it? And I think, like Rabi said, there's definitely a component of RV failure other than due to, because our automatic thought process is pulmonary hypertension causes RV failure. But if there's an infiltrative disease as well, then you might also have primary RV failure via myocyte damage. So this patient definitely has like RV damage, LV damage, definitely has chronic hypoxia, chronic hypercarbia. I did discuss this with pulmonology before VMR, like an hour ago, and I texted them, like the same pulmonologist. I was like, hey, what do you think? Like, what else could there be, or could there be like another etiology? And she said that like she would be satisfied with like a chronic hypercarbia group 2-3 etiology. In terms of like other etiologies we thought of, like vitamin deficiency, like vitamin C, for example, I don't think we ended up checking it that admission. Could be something to check in the future as well. But yeah.
Dude, I love it so much. I had to go back and review my notes on getting to the pulmonary arterial. I was so convinced that that was the cause. But yeah, that makes a lot of sense to me. I just had to go review the PVR, the RA over PCWP, etc. And I love this case so much because you got to it's not about knowing this rare diagnosis, it's about knowing that is like a genetic myopathy that was the most elegant diagnosis.
Speaking of elegant, look at those teaching points. Lyra, take it away, my friend.
Yeah, thank you all so much for this truly mind-blowing session. And it was a lot, but it all started with a patient that presented with progressive somnolence as well as hypercarbia. And if we look at these just two symptoms, we can understand that one can cause another and vice versa. So in order to understand in which direction we need to think, we need to understand is hypercarbia acute, chronic, or acute and chronic, and thus we can look for the level of the bicarb to understand if this is chronic, then there would be some compensation. If this is truly acute, then the organism wouldn't be able to fastly compensate for acute hypercarbia. And also, if we think about the base rate, if we think about lung diseases, it's usually we see chronic lung disease cause chronic hypercarbia rather than acute one. And if we find ourselves in the realm of acute hypercarbia, then we really need to think about other extrapulmonary causes, especially primary CNS pathology. And we can also use the test of treating so we can correct the hypercarbia and see if the patient gets better to understand the driving cause of this confusion in this patient. And also, we discussed a lot about right heart failure etiology. And the interesting thing here is to think about the both presence of both left heart and right heart failure. And here it also exists on the spectrum. So left heart failure can cause right heart failure. And this is actually most common cause of right ventricular dysfunction. But also right ventricular dysfunction can cause left ventricular dysfunction. For example, in long-standing pulmonary hypertension. But also it can occur due to simultaneous problem that affects both the left and right ventricles at the same time, for example, like myocarditis. Also, we talked about confirmation of this theory with the right heart cath. So we need to ask few questions. First, is this really a pulmonary hypertension that we're seeing here? And for the answer, we need to look at the mean arterial pulmonary arterial pressure. The next question we need to ask, is the left ventricle responsible for this pulmonary hypertension that we see here? And we can look at the PCWP value to understand that. But if we have features of both precapillary and postcapillary pulmonary hypertension, we can look at the RA to PCWP ratio value to lean more into one or other direction. If this value is more than 0.8, then we can think more about leading precapillary cause of pulmonary hypertension. If it's less than this cutoff value, then we can focus more on postcapillary causes of pulmonary hypertension. And also, we talked about cardiac enhancement on MRI. And this is really the topic where the pattern matters, because if we see enhancement that goes along the coronary arteries, our primary theory here would be ischemia. But if it's random, as in this case, we can think about infiltration causing cardiac dysfunction. And also, the pivotal point here was when we learned about skeletal muscle weakness in this patient. And here, with the proximal more than distal affected pattern, we really should focus on muscles. But also, if we have hyperreflexia, we can also include in our differential neuromuscular junction diseases. And also, if we see simultaneous involvement of the skeletal muscle as well as cardiac muscle, we need to involve the hereditary muscular diseases also at the top of our differential. And another pearl is that normal CKA as well as hyporeflexia does not exclude the possibility of purely muscular disease. Yeah, thanks everyone.
Lyra, you crushed it. You took such a complicated case and you simplified it so well. It was beautiful. It shows that you are recovered from all your exams and you're ready to be back in the VMR space. Rabih John, what do you have to close us out with?
Goodbye.